Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and your questions will be addressed. I'm honored to introduce our mentor for today, Dr. Chima. Dr. Chima is a clinical assistant professor of medicine at the University of Maryland School of Medicine. She is also a practicing internist and an amazing mentor to many students. And today we are basically going to be having a mixed panel with a pre-med student, a medical student, also a PhD student, all applying to medical school. So it's also today's March 30th, 2024, and it's also Doctor's Day. So I wanted to thank Dr. Chima for her time this morning.
Very good morning, everyone. Thank you, Minahil. I really appreciate. Yes, it's a Doctor's Day, and I would say it's a Community Services Day. So being a physician, we take a privileges to help our community. So I really appreciate we have 3 students with us. One is PhD student, Robin, one medical student, Minahil, and we have Amna, she's a pre-med student. Both Robin and Amna is applying for medical school. So it's a great honor that we all students together and we'll have a more interactive session. So this is how, because students are more energetic, so I get energy from them. So I really feel good to talk to them. And today we'll learn more from them as well, whatever they learned so far. And of course, we'll do it together. So let's talk about what is clinical neurology. So we're gonna learn today about what is neurology. So basically, it's one of the branch of medicine dealing with the conditions that a patient is suffering from to help diagnose the patient and then treat all the categories of conditions and diseases involving the nervous system. Remember, we talked a session before last Saturday about we were talking about brain anatomy briefly, and again, so it's all complete nervous system, which comprise the brain, spinal cord, and peripheral nerves. And I would like to ask the students, tell me the diseases and disorders treated by the neurologist, or you can say, what are the neurological disorders? So Robin, can you give me one name of the neurological disease come in your mind?
Sure, multiple sclerosis.
That's good, very good. Minahil, can you tell me one?
Parkinson's disease or ALS.
Okay, good. Amna, what about you?
Sorry about that. I was going to say stroke.
Good, very good. Right. So these are all the different diseases that include a stroke called cerebrovascular accident, Alzheimer's disease, Parkinson's disease, multiple sclerosis, migraine, epilepsy, sleep disorders. We can chronic pain syndrome as well, and any brain and spinal cord injuries like traumatic brain injuries called TBI as well. And we have a very good shock trauma center in the University of Maryland. It's one of the best center. And then ALS. So let's go over briefly the anatomy, and then I will give you a scenario. So we'll then talk about it. So let's go over briefly again the lobes of, yeah. So there are 4 lobes again. Let me fix it here. Okay, good. So again, so right cerebral hemisphere and left cerebral hemisphere. And now cerebral hemisphere divided into lobes: frontal lobe, parietal lobe, occipital lobe, and temporal lobes. And all these lobes have their functions. So I'm going to give you one scenario. I will discuss one scenario, which lobe is affected when based on that scenario I'm going to give you next. So, and let's also that this next diagram I'm going to talk briefly about. In the lobes, there are different areas. You can see in the frontal lobe, it's called Broca's area. This is the speech area. And then this is the primary motor area. This is the primary sensory areas. So there are different areas. I'm just giving you brief anatomy so you have a better idea when we're talking about it, when we talk about it. So now then this is the Wernicke's area. So go back again, please. Yes, this is the Wernicke's area. So again, the speech area. And then in the occipital lobe, this is the visual area. So we should know that they're subdivided after main lobes: frontal lobe, parietal lobe, occipital lobe, temporal lobes. So all lobes, then there's the different functions of the brain. So let's go, what are the different functions and cognitive domains of these lobes? So frontal lobe can, Minahil, can you read it for me? What is the function? Can you tell me? What are the function of the frontal lobe?
Yeah, the frontal lobe is primarily responsible for executive function like planning, monitoring complex tasks, judgment and insight.
Good, very good. Robin, can you tell me the parietal lobe?
That purple language.
Yes, yeah.
Naming, reading, writing, repetition, and comprehension.
Good, very good. And then you can see all these areas. So sometimes they're interlinked. So like there's this red area, you can see attention, working memory, ability to attend to stimulus. And then this is the occipital lobe. This is a visual spatial function. The location is here. So what it does, it basically for the object recognition, for reading. So these are all the different functions of the lobes. And also this area at the bottom, you can see the memory areas. And the specific area is called hippocampus that helps us with our memory. Okay, let's go over the scenario. Who will read this for me? Minahil or Robin, who will volunteer?
I can do it. So we have a 66-year-old man with diabetes brought to the emergency department because of a change in mental status over the past 3 days. His wife explains that he has just not been himself. He's normally a jovial man who derives an enormous amount of joy from being a grandfather of 3. However, over the past 3 days, he's been apathetic to his grandchildren with mostly sad or flat affect. He stated that he doesn't feel like doing anything because he's tired and sad. He has no known past psychiatric or neurologic history. On physical examination, there's no aphasia, gross motor, sensory deficits, or cranial nerve signs. An MRI will most likely reveal a lesion in the...
Good. Thank you, Robin. So what do you think? What's the right answer? There's no right answer. We are here to learn. So just give your best educational guess, and then we'll discuss in detail.
So emotions could be affected by a frontal or parietal lobe.
Good, very good. Yes, Robin, you're right. So basically, the correct answer is A. So lesions of the left frontal lobe may present with a clinical syndrome as presented in this scenario. And it's sometimes very is indistinguishable from depressive illness. So the clinical key to this presentation is that a patient has a depressive presentation, and secondary to the medical disorder, and there's an abrupt clinical deterioration being over the period of 3 days. So this will be a highly atypical for a primary psychiatric disorder. So that's why we're thinking most likely is a structural disorder, and the lobe effect is the left frontal lobe that is affecting. And the choice B mentioned the left parietal lobe. It may present largely with language and speech difficulties that are absent in this patient's presentation. And the choice C is the right parietal lesions that may present largely with the visual spatial integration problems. They can have some neglect syndrome like symptoms, and they were not mentioned in this patient's presentation. And also the choice D, the option D, is a pontine lesions. So that would be manifested by the cranial nerves. So we'll talk about cranial nerves right after this. And we didn't see any issue with the cranial nerve signs, and multiple motor and sensory deficiencies happens with the pontine lesions because pons have a lot of cranial nerves origin area. And then cerebral lesions, basically option E is not option because largely they are with the coordination. When patient presented with some imbalance issues, with some gait difficulty, so then we think on the cerebellar lesions. And also sometimes they have cranial nerve involvement as well. So it's less likely cerebellar lesions. Okay, good, very good. So let's go over now. The next we're going to talk about the cranial nerves. So this is the ventral view of the brain. So there's a 12 nerves. So first is called, so the number is Roman number 1 to 12, and then they have names. So number 1 is olfactory nerve, then optic nerve, oculomotor. 4th is trochlear nerve. 5th is trigeminal. 6th is abducent. 7th is facial nerve. 8th vestibulocochlear. 9th is glossopharyngeal nerve. 10th vagus nerve. 11th accessory nerve, and 12th hypoglossal nerves. So among these 12 nerves, few are pure sensory and few are pure motor nerves. And other are mixed nerves. Mixed nerve means they both have motor function and sensory function. So when you will be in med school, so you have to memorize all these nerves, then you will be able to understand the cranial nerve lesions. And then we do the clinical neurological exams, that how we differentiate which nerve has been damaged. So clinically we can assess. So it will really a good neurology exam we need to learn. But of course, first of all, we need to know the basics. Basic is first we need to memorize all these nerves, which nerve is which one, which is a motor nerve, is a sensory nerve, is a mixed nerve. Okay, next. So next so this is the pons area. Okay, same diagram. Okay, so there was a diagram. So now this is the real brain, the ventral view. And you can see over here again, this is an olfactory nerve. This is for an olfactory bulb. So all nerves have their functions. So we're going to go over one by one. So this is the pontine area. This is the pons. So you can see the nerves are arising, right? Pons. So we talk about the first question, first scenario, that it's not a pontine lesion because there was no involvement of the cranial nerves. That's why we rule out. So this is how when you will interlink all these anatomy and then you understand. And then, of course, clinical neurology exam helps us to diagnose. And then we are able to manage our patient appropriately. Okay, so this is, now we talk about the cranial nerve functions. So first nerve, olfactory nerve for smell. Optic nerve is for vision. Oculomotor, third nerve for the eye movement. Trochlear nerve is again for eye movement, but this is a vertical movement. So both oculomotor and trochlear nerve, they have eye movement, but trochlear nerve specifically for one muscle. I'm going to ask Amna, can you please tell me which muscle is supplied by the trochlear nerve?
Is it the superior orbital muscle?
Good, you try your best. It's superior oblique muscle. So you can have a memorization SO4. S for superior, O for oblique, 4. So you know SO4, I hope you learn in your biochemistry. So SO4, superior oblique is supplied by the fourth nerve. Fourth nerve is the trochlear nerve. Good. Fifth is trigeminal nerve. It has both supply the facial nerve, facial area. Then abductor nerve is also again for the eye movement. So I will ask Minahil, can you tell me which muscle is supplied by the abductor nerve?
The abducens nerve.
Okay,
The
that's
lateral
fine. If you don't know,
rectus.
it's okay. So lateral rectus muscle, LR, so again mnemonic for this LR6. So lateral rectus muscle. So when you will go you will learn more detailed anatomy, all the orbital muscles or all the ocular muscles, they are different muscles. So mainly the trochlear nerve, fourth nerve supplies the superior oblique, and abductor nerve, sixth nerve supply the lateral rectus muscle of the ocular muscles. And then facial is the seventh nerve, is for taste and facial expressions. Eighth is for auditory, for hearing purposes. Ninth, glossopharyngeal, for again taste. 10th is vagus nerve. You can see the functions over here. Then 11th is the accessory muscles, again for head and shoulder muscles. And then hypoglossal, that apply the tongue movement. So hypoglossal nerve is the 12th nerve. So these all are the cranial nerve functions. So it's very important to learn the cranial nerves, their anatomy, their locations, and then their functions. When we know the normal, then we will be able to differentiate their deficit. Any cranial nerve deficit is there. How we do that? We learn the neurological exam. Okay, good. Next, please. So now we have who will read this for me?
I can read it.
Minahil, you will volunteer?
Yes. A previously healthy 40-year-old man comes to the clinic because of dizziness. The patient states that 1 week ago at 5 a.m., he started to get out of bed to the left and had the acute onset of feeling the room move. He denies any tinnitus, hearing loss, double vision, dysphagia, or dysarthria. He got up and went to the couch feeling somewhat unsteady and his legs felt weak. He returned to normal within 1 hour. Similar episodes have occurred 3 to 4 times since then. He denies any alcohol or drug use, but does take vitamin B complex, ginseng, and ginkgo biloba. During your evaluation, particular attention should be given to which of the following?
Okay, good. So We have a cardiac examination, cranial nerve examination, then C option, mental status, E. So first of all, I would like to ask you guys, what do you think? What's the diagnosis based on this scenario? What do you think? What's going on with the patient? Then we'll see what we're going to do next. Minal, can you tell me? What do you think?
Could we do a cranial nerve examination?
Yeah, you're right. You're right. But I'm asking the diagnosis. What do you think? What's going on with the patient?
He could be having something wrong with the cerebellum, like vertigo.
Okay, good. So as I mentioned, the cerebellum is with the balance and all this. So yes, this patient is giving us a history of vertigo. So the most likely etiology of vertigo is a benign positional paroxysmal vertigo. So it can be in the ears, because inside if we learn more about, sometime we talk about ENT topic as well. So we'll learn about it more in detail. So basically the answer is cranial nerve examination. So why? Why this answer is right? The patient is given the history of vertigo, as I mentioned, called benign positional paroxysmal vertigo. This is because patient has no vascular risk factors at this time. So, and there's no other symptoms. And the events are positional. So as mentioned in this scenario, patient is mentioned has a dizziness with the position. And also this is most likely because the good cranial nerve examination is essential to make sure that there is no brainstem involvement. As Minail mentioned, maybe something with the cerebellum, right? So we have to rule that out because vertigo is not a problem with the cerebellum. So how will we rule out? We'll do the cranial nerve examination to make sure it's not a brainstem involvement. And also the other, the option A, the dizziness, it can be due to cardiac etiology, cardiac involvement, but most commonly it's not the vertigo type of dizziness. Means patient has different feelings. So that's why whenever patient comes with dizziness, so we have to ask detailed history. So patient give us the diagnosis. So we ask the patient, okay, what do you mean by dizziness? So sometimes patients say, I feel like a room is spinning around me. So that is a particular symptom sign for the vertigo. But when patients say, I feel like I'm going to pass out, that's more towards a cardiac. So that's how we have to differentiate which route we have to go and how we have to rule out our differential diagnosis. So dizziness can be because of cardiac etiology, but this is not like positional. And also he has no cardiovascular risk factors at this time. And also, why not the option D? So why not the mental status testing is unlikely because it's very critical in making the diagnosis in this case. And vertigo may be caused by a problem in the cervical region, and I mean spinal cord region of the spine. It can be brainstem, it can be cerebellum, it can be peripheral vestibular structure areas involved. So, but it's less likely in this scenario. But in those situations, very severe cases, patient present with different, with mental altered mental status, and we need further detail. And there's also supratentorial function is affected as well. And why not the option, the position sense and the Romberg sign? These are less likely because these are the tests we do for the dorsal column function. I didn't talk about it this time, but I will sometimes, when we talk more about next time in the neurology section, we'll talk about what these dorsal column function testing is all about. And this again help with the gait unsteadiness, but not with the true vertigo. So let's talk about the diagnostic test in the neurology. So as we learned about basic anatomy, we talk about vertigo, we talk about the cranial nerves. So what are the diagnostic tests? And as we talk about common conditions we come across. So diagnostic tests for neurological disorders are basically, we do the CT scan, we do the EEG called electroencephalogram, we do the MRI of the brain, we do the EMG, there's electromyography, and we do the nerve conduction studies, we do the PET scan, PET, the positron emission tomography, we do the arteriogram, also called angiogram, we do the spinal tap called lumbar puncture, and we do the evoke potentials. So these are the basic neurological testing we do. And I will go pretty quick. What is CT scan? It's basically the medical imaging technique, and we talk about in our prior session as well, to obtain the detailed internal images of the body. So now if a CT scan the brain, it will be a focus on the brain. And then EEG is the electroencephalogram. Basically, it's a test that measures the electrical activity in the brain using the small, there's a small metal disc applied called electrodes that attach to the scalp. And this is how we get the reading of the electrical activity of the brains. And then MRI. MRI is another imaging study we do. It's basically a non-invasive medical imaging test that produces the detailed images of the almost all the internal structure of the body. And specifically, we want to do the MRI of the brain. So basically, all involve the brain, cerebral, and the vasculature as well. Then the EMG. So what is EMG? Is electromyography. It measures the muscle response, or basically or the electrical activity in response to a nerve stimulation of the skeletal muscle. So this is how we do the EMG, make sure is any damage, any deficit in the brain as well. And the PET scan. So PET scan is basically another medical imaging, is a procedure that provides unique information about how an organ or system in the body is working, how it functions. The PET scans are basically mainly used to diagnose some cancer, some neurological brain disorders, and some cardiovascular diseases as well. All right, so let's go over and talk about another scenario. So let's see who wanna volunteer, Minahil or Robin, who wanna pick?
I can do it.
Okay, go ahead.
67-year-old man comes to see you in the clinic to get to the bottom of his problem. 2 months ago, he was lifting something and threw out his back. He initially developed some back pain and then bilateral leg weakness and difficulties with balance. Ibuprofen did not help. At about the same time, he had difficulty holding his head up, so that he now has to hold his head manually with his hands, or else it rests on his chest. He has to throw his head back to see because he has bilateral eyelid drooping. He needs a walker because of worsening leg weakness. In addition to all of this, he has difficulty swallowing and has been short of breath after exertion. He went to the hospital a month ago and had MRIs of his brain, cervical spine, and lumbar spine, all of which had no abnormalities that were inconclusive. He was discharged without being given a clear diagnosis. Today, he presents with worsening of all of these symptoms. Physical examination shows severe neck extensor weakness, severe bilateral ptosis, dysarthria, proximal extremity weakness with preserved reflexes, downgoing toes, and intact sensation. The diagnosis will likely be established with which of the following tests?
Good, very good. Thank you, Robin. So what do you think? So give me the diagnosis. What do you think? What's going on? What do you think is the diagnosis?
Yeah, so it seems like he has some sort of disruption in the communication between his nerves and muscles.
Yes, you're right. Very good. Very good, Robin. I really appreciate it. Yes. So it's basically, and Robin is right, it's a neuromuscular dysfunction as issue, what's called myasthenia gravis. So diagnosis of myasthenia gravis, and basically what is the answer? So answer is C. So most likely diagnosis in this case is a neuromuscular junction problem, such as myasthenia gravis, and less likely possibilities includes the GB Guillain-Barré syndrome or motor neuron disease or some myopathy going on. So what we're supposed to do? So we have to do the EMG. So we talk about electromyogram, right? So we will do the electromyogram because all the scenario is mentioning about some muscle issues, right? So we have to figure out what's going on. So it can be either myasthenia gravis or GB syndrome. So EMG is the correct answer. So why not A? So CT scan of the head, as we talk about, it will be useful to look for the brain anatomy, brain structure, some anatomical problem such as hemorrhage or some hydrocephalus, but it's not that diagnostic for the myasthenia gravis or neuromuscular junction disorders. And then EEG. Why not EEG? So EEG is basically useful in evaluating the patient with severe disorders or some encephalopathy going on. Then we do the EEG. And then lumbar puncture. Why not lumbar puncture? So lumbar puncture, I will show you the diagram, how we do the procedure is basically we take the fluid out from the back of the spine, from the lower back area, and the fluid is called cerebrospinal fluid. And we take it from the lower back, and it use to find or diagnose some problems like some infections, encephalitis, meningitis. So these are the we do for diagnose those problems. So that's why we will not pick the lumbar puncture. And then why not MRI? So basically MRI of is not in this scenario because it is extremely unlikely to explain the cranial nerve findings. So it would show like we can, for MRI, we can see the spine and again, anatomical problem like a CT scan, but of course more detailed than the CT scan, and such as a cord compression. So for the diagnosis of cord compression, MRI will be, we can use that. Okay, all right, so good. So answer is EMG. So when EMG is positive, basically, what does it mean? It means that there's some degree of nerve damage, and it can be called neuropathy. So as Robin mentioned, there's something going on in the neuromuscular junction. So there's an issue with the neuromuscular junction because they have to communicate between the muscles and the nerves. Why we have a pain? When we have a pain, the nerve conduction, there's a nerve conduction study as well. So that conveys the message to our brain that there's a pain in any muscle, in skeletal muscle, right? Or in any organ. So there's an issue with the neuromuscular junction. All right, good. Let's talk about another scenario. It's another neurological condition. So, Minahil, would you like to volunteer?
Yes, I can read it. A 79-year-old woman is brought to the office because of increasing forgetfulness and personality changes over the past few months. She lived alone up until 6 months ago when she moved in with her daughter because she could no longer bathe and dress herself. The family is concerned because she has become suspicious and aggressive. The son says that her thinking is off and that she often gives the strangest responses to questions. For example, when they ask her if she wants to go to dinner, she says that she can't go to dinner because dinner's not a place. She frequently wanders around the house, disoriented to time and place. She does not remember the names of her grandchildren, and she has difficulty finding her words. He says that she always appears a bit unsteady, but nobody has ever seen her fall. She asks you your name 5 different times during the history. She takes no medications, has had no major illnesses over the years, and never drank alcohol or smoked cigarettes. Physical exam shows 2 well-healed scars on her forehead. Laboratory studies show the following. I see sodium 139, hemoglobin 13.5, potassium 4.4, so those are within normal range. Chloride 103 as well, platelets 360, bicarbonate 25, leukocyte count 6,000, creatinine 0.9, glucose 95, calcium 9.2, and TSH 4.3.
Okay, good, very good. So in this scenario, they're mentioning about something about the memory issues going on. So they give the labs as well. So why they mention about the sodium and all this electrolyte? Because sometimes sodium goes up and down. We have some mentation changes as well. So now in this scenario, the sodium is normal. So what do you think is going on? So what can be, do you have options? Let's see, I cannot see the slides here. So let's see.
Yes, it's asking about the most appropriate next step is to A, admit her to the hospital and prepare her for immediate neurosurgery, B, perform a lumbar puncture, C, prescribe a trial of phenylazine, D, schedule her for cerebral angiogram, or E, schedule her for MRI of the head.
Okay, good, very good. So just figured out what we will do next. I have to take one call. I have a call coming for the patient. Just give me a few minutes. I'll be with you.
Okay, so I'm thinking because there are 2 well-healed scars on the forehead, it could potentially, that means something, right? It is talking about surgical scars, or I'm not sure, the well-healed scars. So I'm thinking it might be surgical scar, but the history did not mention any major illnesses. So I'm not sure why or what it was for, right? Sometimes people say that scars tell you like a lot of the patient's history. So always do like a physical exam, check for scars everywhere because it could be a surgical scar. I wouldn't say it would be A either because it doesn't seem like a neurological emergency.
Okay, good, very good. So even though the patient clinical history is most consistent with the Alzheimer disease, basically it's the slow and the insidious onset of the memory loss, then the language impairment, there's a visual impairment, some delusions, some hallucinations, and the loss of interest in activities. So MRI may rule out other conditions that may mimic this common dementing disorder, such as we can say a chronic subdural hematoma can cause it. Some other condition like so this should be ruled out first, because the son is mentioning that patient is unsteady, and there is also some scars on her forehead that may indicate the falls in the past. That might need some suturing, that she had a fall in the past, or maybe she had some subdural hematoma that neurosurgery has to do some procedure on her. So that might be the cause. So this may present with the headache. It can present with the confusion. It can present with the slow thinking process. It can present with the personality changes. It can present with some behavioral changes. So it can be caused by a very minor injury. So MRI can also be useful in differentiating between the Alzheimer's disease and multi-infarct dementia. So because MRI get more details about it. So that's the reason. And also it's inappropriate to admit her to the hospital and prepare her for immediate neurosurgery at this time, because the patient already has a dementia, which is most likely due to the Alzheimer's disease. And neurosurgery has no part of it. There's no treatment for, from neurosurgery standpoint view. But of course, if there's a chronic, there's acute subdural hematoma that they can help to evacuate, or they can help us doing some procedure. But a chronic subdural hematoma should be ruled out with an MRI first. And if there's a chronic subdural hematoma is present, so there's a we can use corticosteroids, and we can use surgical evaluation may be necessary before having any intervention. Why not the option C? Because it's not appropriate at this time, because even though it's sometimes difficult to distinguish Alzheimer's disease from depression. So these are the signs and symptoms that may consistent with the subdural hematoma, and therefore MRI should be performed. And sometimes the trial of the antidepressants may be is appropriate in some cases when we diagnose with them with a depression. However, the most appropriate agents that we use are the tricyclic antidepressant, or SSRIs. And but phenerzine is a monoamine oxidase inhibitor. It's called MAOI. So we have to choose a tricyclic antidepressant first choice. So we should not be used after others options have been unsuccessful. And the last option, the D, other option, the clinical angiogram, is useful in evaluating the morphology of the cerebral vasculature. So I remember from the last session, we talked about the cerebral vasculature, all the blood supply of the brain, and to detect the location and degree of the atherosclerotic disease or any stenosis in the vasculature of the brain. So as well as some other malformations like aneurysms. So then we can use a cerebral angiogram. All right, good, very good. So now the second part of this question, Minal, can you read it again?
Yes, a 79-year-old woman is brought to the office, so it's the case. And the next question was asking, the appropriate steps are taken and either no abnormalities are found or she did not respond to the treatment. So the most likely diagnosis is Alzheimer's disease, chronic subdural hematoma, depression, multi-infarct dementia, or schizoaffective disorder.
Yes, good. So as we talk about it, its most likely diagnosis is Alzheimer's dementia in this scenario. So this diagnosis is of exclusion. Why? Because it's characterized by the slow, as we talk about, slow and insidious onset of the memory loss. There's a language impairment, there's a visual impairment, patient has some delusions, patient has some hallucinations, and also mentioned there's loss of interest in the activities as well. So this patient has most likely most of these symptoms that go towards the Alzheimer's dementia, and we have to rule out by doing the lab studies and doing the MRI. So I would like to stop here. As we and the subdural hematoma, I talked briefly about it. We need MRI to rule out. Then for depression, we talk about is because history is going more towards, is more classical for the Alzheimer's disease. And then why not the multi-infarct dementia? Again, is typically a stepwise progression in the multi-infarct dementia. That's why these are not the right options at this time. And then given the slow and insidious onset, it goes more towards the Alzheimer's disease than multi-infarct dementia. And also we need the MRI to rule out multi-infarct dementia. And also, why not the schizoaffective disorder? Because it is characterized by the presence of psychosis. Of course, patient has some symptoms, but it's not like typical psychotic symptom. The patient does not have psychotic symptom, and that's the reason patient is more characterized and more characteristic of the disorder, such as they have a very bizarre hallucinations, and also they have some weight loss. They have insomnia, they have feeling of guilt, they have feeling of worthlessness, and sometimes they have suicidal ideation as well. So that's why we will not we will rule out schizoaffective disorder. All right. So typical Alzheimer's disease, I would like one of our students to talk more about it. And then, as I mentioned, it's basically the episodic memory decline, first of all, and then there's a cognitive disorders there as well, and how we treat it. So I would like, Midahil, if you were gonna go over and talk about a little bit about Alzheimer's disease, so we all will learn. and then I will briefly talk about the treatment of it.
Thank you so much, Dr. Chima. Yes, I'll start sharing my slides now. And this is a good segue into Alzheimer's disease and neurodegenerative diseases in general. So I'm going to be going over a brief epidemiology of clinical manifestations of neurodegenerative diseases, and specifically we'll focus more on Alzheimer's, the cellular mechanisms that underlie it, and also some therapeutic approaches very briefly. And Robin, feel free to pitch in anywhere that you'd like. So what I find really interesting, and this is an interesting fact I learned, is that the most common mechanism of neurodegenerative disease is the toxic aggregation of proteins. So remember, proteins are made out of amino acids. Amino acids, we learned those for our MCAT. And so a fancy name for a toxic aggregation of proteins is called a proteinopathy. What's very interesting about this and how I like to make an analogy is basically we always learn about sickle cell disease. I remember I learned that in high school and again in college. And basically, sickle cell disease is when there is an amino acid substitution that causes the red blood cell to become sickle in shape. The reason why is because it switches from a glutamic acid to a valine, and valine is more hydrophobic, which causes it to basically suck in or sickle in shape. Similar to this, like proteins, again, are made out of amino acids. So this happens in something like this happens in the brain or in neurons and brain cells. Something similar happens where if these proteins all aggregate and they're meant to be broken down, it can lead to a proteinopathy. And so neurodegenerative diseases are really linked to proteinopathies, and we're still learning more about it, but this is the most common mechanism. And so these are some of the more common neurodegenerative diseases. There are tauopathies, which is a specific type of toxic protein. What ALS is caused by TDP-43. There's also Huntington disease. There's also prion diseases like Creutzfeldt-Jakob disease. Synucleopathies, which include Lewy body dementia or Parkinson disease, vascular dementia, like Dr. Chima talked about. But we're going to be focusing more on Alzheimer's because that's the most common neurodegenerative disease. And the rest of these you will definitely learn in medical school when you're in your neuro units. So we learned a little bit about anatomy during Neurology Month and in the beginning when we learned about clinical neuroanatomy. And again, we had the review with Dr. Chima. The reason why it's very important is because form follows function. So if there's a toxic aggregation of proteins in the cognition pathway, that might affect the cognition of the brain. If we're affecting the parietal lobe or hippocampus and these proteins are all aggregating or accumulating in the memory centers of the brain, then we might have an effect in the memory of the brain. If it's happening in the cerebellum, it may affect coordination. So that's why understanding anatomy really matters, because if you know what each part of the brain does normally, then you'll know what happens if it's not functioning anymore. That's actually how in the early days of neuroanatomy and historically, this is how we'd actually learn about different types of neurodeficits. Basically, before we had all these fancy imaging like MRI or CT scans, scientists of the past, like 1900s, 1800s, they'd be able to diagnose like Broca's aphasia or Wernicke's aphasia just by looking at deficits in the brains post-mortem. So after looking at the cadavers of people who had like word salad or had subtypes of specific word aphasia, they would find these correlates where, oh, okay, the brain sections here don't look normal, they look different. And so that's how I'd be like, okay, this is Wernicke's aphasia, this is Broca's aphasia. In fact, Broca discovered Broca's aphasia, Wernicke discovered Wernicke's aphasia. So that's actually how those aphasias were discovered. So now let's switch gears a bit into dementia and Alzheimer's disease. One may be wondering, what is the difference? Are they the same thing? Are they not? So basically dementia, and this is actually from the Alzheimer's Association website I took this picture from, where basically dementia is this umbrella term for the loss of memory and other thinking abilities that interfere enough with your daily living or your adult daily activities. And specific types of dementia include Alzheimer's, which is the most common, vascular, Lewy body, frontotemporal, and others, including Huntington's disease. And there might also be mixed dementia, and because dementia can come from more than one cause. So again, Alzheimer's is a type of dementia, and Alzheimer's is also a cause of dementia, if that makes sense. So dementia does not cause Alzheimer's. It's rather Alzheimer's causes dementia because it's a type of dementia. So in fact, it is the most common cause of dementia, Alzheimer's disease, which accounts for about 60 to 80% of dementia cases. And again, dementia just a general umbrella term for symptoms of memory decline. So let's talk a little bit more about like mild cognitive impairments, because basically dementia or memory loss is sort of a spectrum. Before we actually get into diagnosing really actual Alzheimer's disease, essentially. So basically mild cognitive impairments, they are essentially subtle changes in cognitive abilities that are noticed by the person affected or by family members and friends. And mild cognitive impairments, or MCIs, they may not actually affect the individual's ability to carry out everyday activities, so their function tends to be preserved. And also, it may be difficult to differentiate from normal aging, because 12 to 18% of people who are affected by a mild cognitive impairment are over the age of 60. And in fact, like 1/3 of people with MCIs, they develop dementia within 5 years, but some also can return to normal cognitive function based on how it goes. Another saying is that basically, if you don't use it, you lose it. There are some studies that show that more geriatric patients who do more like Sudokus or puzzles or more like cognitive enhancing activities like bird hunt or Scrabble, their brain function tends to be more preserved, and there's this correlation. Basically, in families, they may come and present to you with their father or elderly father saying like, okay, I have a concern about change in cognition with my dad. He's just, but they do have preserved independence. So like they do have functional abilities and they do have preserved social and work function. And so the impairment can be attributed to other things too, like trauma, infection, UTIs in older patients tend to come with mild cognitive impairment. So you want to try to rule out other causes like depression, trauma, infection, or chronic medication or substance side effects. And so that's basically a little bit about mild cognitive impairment. And so it can progress to Alzheimer's disease, but not always. But this is sort of the spectrum where there's moderate to severe and mild dementia due to Alzheimer's disease once it becomes mild, moderate, or severe. All right, so now let's talk about Alzheimer's disease. Alzheimer's disease is actually the only neurodegenerative disease as defined by two simultaneous proteinopathies, which basically means that there are two types of proteins that toxically aggregate. And the main symptom of Alzheimer's disease is memory impairment, which is why I tried addressing the dementia and mild cognitive impairment before talking about Alzheimer's, because it's a more severe form. And so what exactly is Alzheimer's? It is associated with age. It's an irreversible and progressive neurodegenerative disease. It comes with dementia and a loss of cognitive skills like memory, thinking, and reasoning. Remember, this is different from mild cognitive impairment, and it was discovered by Dr. Alois Alzheimer, which is why it's named Alzheimer's disease. And here I pointed out again, the form follows function, where the main two lobes in the brain that are affected are the frontal lobe and temporal lobes. But yeah, these are basically, as science progressed, basically scientists were able to find the specific plaques in postmortem brains of patients who had suffered from elderly or senile dementia. Now let's go over the epidemiology, or basically some facts and figures of why Alzheimer's is important. First, there's a risk factor of age. Increasing age is the greatest known risk of having Alzheimer's disease or past head trauma and vascular disease as well. It's also genetically inclined. Basically, Alzheimer's disease is a autosomal dominant condition. So people who have like a family history have a higher risk of having Alzheimer's disease. These are the main 4 genes that are known that are associated with Alzheimer's. Basically, we have these two protein aggregates, the amyloid beta and also tau, which we'll see in the next slide. But basically, the more risk factors, of course, includes age. What a fun fact I found was that the risk for Alzheimer's actually doubles every 5 years after the age of 65. Also being female. In fact, 2/3 of Alzheimer's disease patients are over the age of 65, a lower educational level, which is why I said if you don't use it, you lose it. So that's why people who have lower educational levels may have a higher risk factor, which is why it's encouraged to do some more cognitive puzzles and things like that at an elderly age. Of course, also the gene APOE4 status. There's also some other risk factors associated with genes, because sometimes it depends on your environment, because you may have the gene that inclines you towards Alzheimer's disease, but the environmental factors may activate it. So you may have it, but it's polygenic as a result. Polygenic basically means that there are a lot of different genes associated with it, and also it depends on your environment and pollution and other risk factors. It's still being researched, actually. And we talked about my family history. There are also some modifiable risk factors as well. And also race and ethnicity. Let me see. Yeah, I have the race and ethnicity here a little bit more in more detail. Basically, African Americans are 2 times more likely to have Alzheimer's disease, and Hispanics are 1.5 times more likely. In this chart, basically, of the United States, it talks about the projected changes between 2014 and 2025 in Alzheimer's disease by state. And so purple basically means the greatest change, and green means the least amount of change. I just found it pretty interesting how it's very different. You can see here the dark purple are more rural areas. And so rural health and rural areas also come with their own disparities. Alzheimer's disease is also the 6th leading cause of death in the United States. You might be wondering, if it's just a cognitive impairment, why does it lead to death? So I'll show you why. And also the most common life expectancy after the diagnosis of Alzheimer's is 4 to 8 years. Now I'll go over that one slide I skipped here, the global impact of dementia. I find this very interesting infographic. So I'll actually just touch on like basically the main things that we should go over, I suppose. Essentially, there is a huge, basically 60 to 80%, we talked about before, 60 to 80% of them are dementia, right? In the United States, there are over 6.5 million people who are diagnosed with it over the age of 65, and only about 1/10 of Americans are under the age of 65. So basically, over age 65 is its own risk factor. And there's also a large economic burden, because the national cost of caring for people with Alzheimer's is over $300 billion. So it's hard to, and here it says that it'll cost, the total estimated worldwide cost of dementia overall is 1 trillion, but we're talking about Alzheimer's, which is over 300 billion. Either way, billion or trillion, we're in large numbers. And in fact, there is actually $271 billion of unpaid care by family and friends in 2021. Because like we said before, patients who pass away, if they still have some medical debt, it's not like student loan debt. Student loan debt dies with you, but not medical care debt. And that tends to go to families and friends. So that's what I find pretty interesting. Yeah, and here there's also a map here that shows the number of people living with dementia. Most of them are concentrated in Asia. But yeah, that's sort of the global lens, and also the local lens, and how expensive it is costing the US about $2 trillion by 2030. We talked about this, or 5 million Americans currently are living with Alzheimer's disease. And now let's talk a little bit about clinical manifestations. We've talked about before dementia, memory impairment, judgment and reasoning changes that we saw in the case study that we went over, planning and task execution disruption, also some personality and behavioral changes. Now, sometimes a patient may not be able to address their own personality or behavioral change, so it tends to be reported in the history by family members or friends. And remember, we want to try differentiating it from memory loss from normal aging and symptoms of Alzheimer's, because Alzheimer's disease tends to be more so concentrated in short-term memory loss, where they forget whole experiences. Whereas in normal aging, you forget a part of an experience. Also in Alzheimer's, you tend to, as it progresses into more severe, you tend to be unable to care for yourself. So you lose the independent functioning. Whereas we talked about before in mild cognitive impairments, function tends to be preserved, and adults can tend to still be able to function independently. And we talked a little bit about the stages, right? There's MCI, the mild cognitive impairment, and there's mild, moderate, and severe Alzheimer's disease. The ADL stands for adult daily living. Again, activities of daily living in adults. So basically you, and in severe Alzheimer's disease, you are totally dependent on your family members, or in a skilled nursing facility, or basically an adult group home. All right, so this is why I was hinting at before, why it could lead to death within 4 to 8 years of diagnosis. So you can look at, this is a normal brain, this is what our brains all look like, and this is a brain with Alzheimer's disease. You can see that there is this global atrophy global cortical atrophy. You can see here, this is not just an old looking brain. This is a severely old, it's much worse. In just elderly patients, the brain does not shrink that much. There's not that much atrophy. Atrophy is just another word for shrinkage or degeneration. So this is all post-mortem brain tissue analysis. You can't actually, check out the brains with the patient still alive. This is actually after. And after family members give permission to actually fully diagnose Alzheimer's. Essentially, there's brain atrophy. As you can see here, this is a cross-section of the brain. Normally, this is what it looks like, even in old-looking brains. But this is how it looks like in Alzheimer's disease. You can see here the white matter changes and also the just overall atrophy. It's smaller, much, much smaller. The ventricles are much more defined here, as you can see here in the cross-section, normal versus Alzheimer's. So now we kind of have an idea of why this could potentially lead to an early onset of death, because if your brain function overall is decreasing, that can lead to overall changes in cognitive testing. So remember we were talking about before how Alzheimer's disease is the only disease that has two proteinopathies. They are the two main proteins that tend to aggregate are amyloid beta plaques and neurofibrillary tangles. And so this is a plaque in this histological stain here, and this is a tau tangle. So we'll look here. Here are some more better images of this histological stain. In this stain, you can see here, this is a neuritic plaque, and this is basically the pathological changes that you see in Alzheimer's disease. We would not see this in normal patients. This plaque is basically this accumulation of toxic proteins. It's a proteinopathy. Here's another neuritic plaque in a different type of stain. We don't have to worry about the different types of stainings. It's just to confirm further, in these different types of stains, you can still identify these different types of plaques. And then on the right side here, you'll see the neurofibrillary tangles. They look like this. So I always remembered it, it's like a triangle. This is not really a triangle, but it's just sort of a teardrop looking shape. So I think tangle, triangle sounds pretty similar. That's sort of how I remember it. It is a teardrop shape, but I just think of a triangle has three sides to it. So that's sort of what they look like. And I remember I once asked my lecturer, like, what is this thing inside of this tangle? This is actually an inclusion of a phosphorylated tau protein. And we'll talk a little bit more about what causes this phosphorylation. We'll talk a little bit more after we go finish up the clinical manifestations. So on MRI and CT scans, the brain morphology, you can see here, you can compare from normal MCI and also Alzheimer's disease MRIs. So this is from the Mayo Clinic. These images essentially show more progression of the disease. You can see here, the vasculature is much more defined here and much more shrunken compared to mild cognitive impairment and normal. So you can just think of this as a spectrum from normal MCI and Alzheimer's or more severe Alzheimer's disease. And also we can do PET scans as well, where you can try to detect those different toxic protein accumulations. So in PET scans, you can see here, in this specific type of brain scan, the red means more amyloid. So this is a more normal brain, and this is where you'll see this is more of a Alzheimer's brain. And here as well, you can see here in normal, PET scans essentially tell you the activity of your brain. And so the Alzheimer's brain here is basically showing you the opposite compared to a normal brain. Your function where it's supposed to be functioning is not functioning. You can see here the executive function, the frontal lobe is much more decreased. In red basically means there's more metabolism occurring. More metabolism is a good thing. That means your brain is working and operating. So essentially in a normal brain, this is what your activity should look like. But here, you can see here in the dark blue areas, this is where activity is not occurring. All right, now let's delve into the science. I remember this is sort of what my degree was in undergrad, and this is what I've learned. But I never really understood the clinical applications really, because you want to try to know what is actually causing the Alzheimer's disease and why the brain is shrinking, why it's happening. So it's a variety of reasons. It can be inflammation, oxidative stress, the mitochondrial dysfunction. This is why we learned about the mitochondria. This is why we learned about calcium homeostasis, synapses, and the action potential we learned in our previous session, and beyond just the abnormal protein function, of course. So beta amyloid, this is the first protein that's abnormal. So when they accumulate, they're basically the number one most important feature in the disease onset of occurring, because basically Now, these are normal, essentially, like these are natural products of metabolism, but if there's too much of them and there's no homeostasis, then it throws things out of balance. So essentially, this is the most prevalent benign one is the beta 40 amyloid, but if it becomes beta 42, it's prone to aggregation, it's more cytotoxic. Similar to the example I gave before, the simpler example of sickle cell disease, of things accumulating. Just one thing can go wrong and can cause sickle cell disease, right? Just one, basically just one substitution instead of glutamic acid is a valine. This is very similar. Just a difference of just two more peptides can lead to Alzheimer's disease. This is more of a basically a molecular view. That this is our cellular membrane. These are basically rafts and non-rafts, and what this is basically showing you is on the left, this is more of a normal. This is what normally happens in our brains. On the right is amyloidogenic disease process, which happens in Alzheimer's disease. Essentially, if you have more of these, it's not good because it'll express in a nucleus and this will just multiply and occur more. So I'm just sort of very simplifying what goes on with the amyloid beta plaques. So there's still ongoing research going on, but basically the hypothesis is that the more aggregates occur, the worse it is or the more severe the disease onset happens. So the more severe Alzheimer's is, it's correlated with the levels of more oligomers, or basically polypeptides, which are the assemblies of the peptides, which can vary in size, but the more there are, the more they accumulate, the more they cause disease dysfunction. So rather than the total amyloid beta burden. So this is still an hypothesis, but this is the leading hypothesis right now for the cause of Alzheimer's disease. And basically, this is a stain. Remember, we see a lot of these stains in MCAT, on the MCAT. And essentially, this is telling you that this oligopolymer, and here you can see here, the more oligomers there are, the worse it is. And this is what's more detected in Alzheimer's brains. So sometimes during test questions, they will show you this without actually telling you that this is an Alzheimer's disease case. But if you see here that there are more amyloid beta plaques or neurofibrillary tangles, then you can assume that this is an Alzheimer's disease case. Now, the other abnormality is tau, and tau is that's just the tangle. That's just another name for the neurofibrillary tangles. And essentially it's talking about the aggregation of these. Normally, in normal quantities, they are helpful for us. They're important for our microtubule and vesicle transport, but in Alzheimer's, they become phosphorylated, which basically means a phosphate group is added to tau, and that leads to protein aggregation. It is insoluble, and basically in the membrane, it's not able to leave our cells. So you can see here, in this, basically these circles, these sphere-looking shapes are phosphate groups. And if basically this tau becomes hyperphosphorylated, which means it has more of these phosphate groups, it leads to a destabilized microtubule. Remember, microtubules are very important for cell transport and function. If the cell is not able to do these basic functions, it will not function properly. It will lead to the hyperphosphorylated of tau proteins, and then it'll lead to neurofibrillary tangles. So the tau is basically the precursor. Once once this microtubule falls apart, this is why the brain eventually shrinks, because the cells are just sort of combusting because of neurofibrillary tangles occurring. This is a very simplified explanation, and you can look at it more. There are a lot of studies. I'm just very going over the surface level and just explaining sort of at an elementary level. But it's very, very fascinating how one wrong thing can occur, leading to the neurofibrillary tangles that we see in histological stains. So as a result of all that biology and molecular biology I showed you, it will lead to synaptic failure in the brain. Now, you can think about it like I said before, sickle cell disease happens with red blood cells, but this is happening in neurons. Now, if this is happening in neurons, then it'll lead to synaptic failure. So that's why there's that memory impairment. That's why there's that global cortical atrophy. That will lead to a reduction in just overall your synapses moving forward. Remember, we talked about the action potential last time. So without an action potential, your brain is just not braining the way it should be normally. In the short term, this will just lead to a basal transmission of impulses. So basically the impulses will occur, but they're just not going to be spread throughout the brain. But in the long term, this will cause an imbalance between the long-term potentiation of the action potential, and it'll lead to a long-term depression of the brain, basically not clinical depression, more so depression of meaning reduced activity depression, which will reduce the number of the dendritic spines in our axons. So this actually leads to why is the synapse important? It's important because it releases neurotransmitters. Now, less neurotransmitters are being released as a result, or maybe they are being released, but they're actually just not being used up by the next synapse in the next neuron cell. So in the late onset of Alzheimer's disease, these levels are severely reduced because no synapses, which means no spread of the neurotransmitters. And so that leads to a decrease in acetylcholine signaling, which is linked to the buildup of tau as well. So all these things are actually just explaining why there are these two proteinopathies occurring, the aggregation of tau, which leads to neurofibrillary tangles, and the aggregation of the amyloid beta plaques. So you can see here as well. And also there's a link with calcium. I'll go over this very briefly, but the elevated cytosolic calcium as a result of the synapses just not absorbing the calcium and transferring it to every neuron and cell, it leads to basically an imbalance in calcium. We need calcium in our brains to survive, but it's just not occurring properly. So essentially, it's just not, this is basically an explanation of a dysfunctional calcium involvement. So elevated calcium in the cytosol instead of where it's supposed to be in the membrane or in the specific neurotransmitters or in the synapses, it'll stimulate more aggregation of the amyloid beta plaques. And now there's also mitochondrial dysfunction that I hinted at before, but the accumulation of the beta plaques, they lead to damaged mitochondria and brains with Alzheimer's disease as well. And now remember, we've learned a lot about what mitochondria does for us. Even before starting medical school, we've learned how important it is in our specific metabolic cycles. And so without the mitochondrial enzymes like cytochrome C oxidase, that means that I'm disrupting the electron transport chain. There's reduced ATP production. So again, without ATP, we can't really function our cells. Our cells rely on that ATP. And that membrane potential becomes dysfunctionated. There's less oxygen consumption in the brain, which is, again, overall, remember, I'm thinking big picture, overall leading to a smaller looking brain. And it's very important because mitochondrial DNA both in Alzheimer's disease, and also you also have your normal aging occurring because, like I said, it's affecting patients over the age of 65. So it's overall just accelerating that aging in the brain, and it's like an exponential increase in aging, which is very different from normal aging. And overall just very bad for you essentially because it's affecting your mitochondria, your calcium, homeostasis, etc. And finally, oxidative stress. Oxidative stress happens because of the release of free radicals, because once mitochondria become damaged, they release these basically signals to the rest of the body, like, hey, my mitochondria is damaged. It leads to free radicals accumulating, but if nothing is helping the brain fix these mitochondria, because the brain just becomes so overwhelmed, it can't. So it leads to more oxidative damage, the aggregation of these proteins leading to more oxidative damage, and that will make more further pathologic changes. And so that's why those histological stains I showed before, those are clinical manifestations of these molecular things occurring, right? Those things that we saw, those, I can show you here again. Yeah, here. This basically what I'm explaining right now is what leads to what we see here, the clinical manifestation. So we went over calcium, mitochondria, oxidative stress, and again, mitochondrial dysfunction, oxidative stress tend to be linked together. If anything goes wrong in the mitochondrial electron transport chain, it can lead to oxidative stress in many different pathways. And overall, remember, oxidative stress leads to inflammation. So as a result of inflammation, it will lead to the release of pro-inflammatory cytokines, and remember, this is the brain sort of signaling oxidative stress. This is basically our immune system kicking in interleukin-1, interleukin-6, TNF alpha. This will basically activate our complement pathway to try to fix these things, but because there's just so many activated microglia, it will just help the protein just keep on aggregating. So our brain just becomes overwhelmed in the response, and it'll lead to inflammation, and that is just helping really the aggregation of the beta amyloid plaques and also the neurofibrillary tangles. So now let's talk a little bit about the therapeutic approaches to Alzheimer's disease and what are some things that we've been doing to try to address this before it gets to a severe onset and try to, sort of increase the longevity of people with Alzheimer's disease. So right now there's no cure. And the side effects of disease can be slowed through the cocktail of medications that exist currently, but most of the drugs are in the trial phase and they have not shown overwhelmingly significant results yet. But a lot of these components they are targeting to reduce the number of plaques, reduce the number of tau aggregates, or so that way they'll lead to a reduction in the neurofibrillary tangles. They're trying to address the oxidative stress and mitochondrial dysfunction before it occurs, also to reduce inflammation, to increase calcium levels where they're supposed to be increased rather than the cytosol, try to make that microtubule stable, even if, so try to reduce the amount of hyperphosphorylation, so removing those extra phosphate groups that aren't supposed to be there, and try to control the oxidation levels of cholesterol as well. So currently, there are 3 medications right now that can be prescribed for Alzheimer's disease that are FDA approved. There's donepezil, galantamine, and memantine. These are the generic names, and then they're also brand names. But for our purposes, for step 1, we always use the generic names. We learn the brand names in residency, which is super fun. But they have their common side effects. But basically, let's talk about donepezil. This is the most prescribed one. This is basically a cholinesterase inhibitor to treat symptoms. So this is basically preventing the breakdown of acetylcholine in the brain. So this is trying to help one pillar, but like I said, there's so many other pillars, so many other factors that are happening in Alzheimer's disease that it's very difficult to address all of them with just one medication. But I think that when there's a will, there's a way, and the Alzheimer's Association is still trying to find a cure. Then there's memantine. This is basically an antagonist that's also to treat moderate to severe Alzheimer's disease. This is not prescribed in mild cognitive impairments, whereas galantamine is. But basically, what memantine does is that this will block the toxic effects associated with the glutamate and and it regulates glutamate activation, which is one of the neurotransmitters in the brain. But they come with their own adverse side effects, right? There's no medication without side effects, but it may lead to nausea, vomiting, diarrhea, and then for memantine, it can lead to dizziness, headaches, constipation, confusion. All right, so that sort of brings me. Yes, go ahead, Robin.
So I was just going to say, if you look at the literature of these approved drugs, there's really no difference in cognitive performance in people on and off the drugs. They have very, very little effect. And we've been functioning on this amyloid hypothesis for a long time, that there's amyloid buildup that happens before we see the buildup of tau. So a lot of companies have tried to target amyloid specifically, and that's basically been like a multi-decade failure. But Eisai did recently have a drug that was approved. It's the first one in a long time. It's an antibody against amyloid. So that's really exciting. It's like the first anti-amyloid drug that looks like it's having a significant effect. But there's a lot of negative side effects with symptoms like that. Like a large proportion of patients still have brain bleeding from these kinds of antibodies. So we have a long way to go. And from a basic science perspective, what makes these disorders so challenging is these proteins, we don't even necessarily understand what their function is in a normal, healthy brain. So when they're like losing function or gaining toxic functions in a disorder, it complicates it even more. So we can't just get rid of them because they're really important for normal function.
Yes, I agree. Yes, Robin, thank you for sharing. I really appreciate it. Yes, definitely, I agree with Robin. And so I will briefly talk about the donepezil as mentioned, that it's basically enzyme inhibitor, acetylcholinesterase. And currently it's an FDA-approved medication, but of course, it helps with the both mild, moderate, and severe Alzheimer's symptoms. And currently there is no evidence that suggests that the donepezil can alter the progression of the disease. But it can improve the cognition, behavior, and sometimes they help with alleviating the certain symptoms. So as you know, many undergrad, you guys learn about the acetylcholine, right? And sometimes we get frustrated why we are learning the biochemistry, right? So I'm gonna give you some fun fact that, of course, when we apply clinically, we feel good. Okay, why we learned about acetylcholine, what is acetylcholinesterase enzyme. So basically, donepezil, the mechanism of action, I want to talk briefly. It inhibits the enzyme, basically breaks down its acetylcholine, and after it's released from the presynapse, and by binding reversibly to acetylcholinesterase, donepezil inhibits the acetylcholine hydrolysis. So thereby, it increases the acetylcholine availability at the synapses and enhancing the cholinergic transmission. So that's the mechanism of action of donepezil. And of course, it's a chemical, it's a neurotransmitter that carries messages from our brain to our body through the nerve cells. So it's that nerve conduction. It helps with the nerve conduction, and it plays a vital role in both brain and our body functions. And basically, it involves the smooth muscle contraction as well. It helps with the blood vessel dilatation as well, produces some bodily secretions, and also helps us slow down the heart rate. All right, so I will stop here, and thank you, everyone. Thank you, Minahil. Thank you, Robin. I really appreciate your input and talking about. And next time we'll make it more interactive, and I would like all the students who are joining us live, would like their contribution as well to be made more interactive. So, at the end, I always talk about some pep talk, right? Some self-care. So definitely, I would like to share with you the keys that help me to be successful. Or everyone use their own keys. So the keys that help me, I would like to share. First of all, before discussing the keys, I will talk about the self-care. I always talk physical health, emotional health, mental health, and spiritual health. So all 4 areas, I always talk, the table has 4 legs. So please try to focus on all these 4 areas to have a balanced, healthy life. And why we need self-care? We need self-care because when we will not be healthy, how will we help others, right? We want you all be future physicians. I would like your health, mental health, physical health should be in a good shape. All right, good. So I would say medicine is one of the best professions. Of course, there are other professions as well. I can be biased, but I feel blessed to be in this profession because I feel that I go closer to more our creator. I learn about my body, and I can, if something going on with my body, I know what's going on, right? Because I learned about anatomy, physiology, pathology, then how to manage. First of all, this is a blessing that you know your body. And then you are able to help others as well. So there are a lot of ways of doing the community services. Like these days, there are many ward zones area. You can go and help. There are many physicians going there. One of my friends just left yesterday. I feel so proud of her. She just left yesterday to help the underserved, underprivileged areas in Gaza. There's a big fire, a lot of war going on there, but they went with the UNO. I really appreciate WHO and UNO who are helping these doctors to go there and help the underserved people there. So that's the reason I'm bringing up with you. When you will be a physician, you will have all these opportunities to help others, pay back to the community. So I always say 3 P's that help me: the passion. Your passion and profession should be the same. Because if your passion and profession should be the same, you will not work a single day. I always give the example, when you're passionate about something, you are out of time and space. Like one of the friend who left yesterday, she was working, all of a sudden she got opportunity. She said, okay, yes, I have to go. Why not? So she just left for 2 weeks. And of course, it's very scary. They told UNO, WHO, they warned all the doctors, anything can happen to anyone. Of course, UN Convoy will be with them. There's different hospitals. There's all the built up there, temporary hospitals are there who are helping at the level best. So of course, they need physicians because they get burnout. There's too much, they need a lot of surgeons, the anesthesia, OBGYN. So they need a lot of help there. So if you're passionate about it, you will definitely help yourself, help others. So be passionate. That is I would say, you will, one day I would expect that you will start helping others in one way or other, like starting with the students, helping other community services, even give advice to other people. Like if you're a senior, start helping others now, like your juniors, start helping them now, give them help with the MCAT, give some tips, how you did it. So everyone has their own ways of doing this stuff. And second P, I say perseverance. I hope you already learned the story about turtle and hare, like keep moving, keep walking, even small baby steps, like small ant step. One day it will be big step like elephant. So please never ever give up whenever you decided. Of course, you will have sacrifices, you will have ups and downs, but be persistent, perseverance. It will help you at the end. At the end, you will say, okay, I was persistent, and it will pay you back. And then last but not least, where did it go? Yes. So I always say my last P that I did, practice. So there's no magic in the word. Practice, practice, practice. So like undergrad students, So I had exposure like this. It was very tough. So yes, definitely the biochemistry is very hard to digest. So just chop the information and practice multiple times. Like if you forget, like Krebs cycle, you're forgetting. So just print it, put in front of your study table. So every time in and out, sometimes you feel it's a brain teaser. Yes, we all have gone through this. I was in your steps, in your shoes as well. So just keep eyeball 3-4 times a day. So you will see it slowly, you will start digesting the information that is hard for you to digest. And also last week I was at one of the dinner, there was Johns Hopkins students and University of Maryland students were there together, and they were mentioning their struggles as well. So don't think you are alone, you are the only one who is struggling. So we all have struggles, we all have sacrifices. So please feel free to contact me, anything I can help you with, excuse me, with your MCAT, with your medical school help, with your USMLE exam. So there's a lot of help available. Of course, online, there's a lot of options available. So please feel free, and please add mentors in your life. Mentors should be your from academic standpoint, from your health, from your spiritual health, your emotional health. Please add mentors in your life, and they will make your life easy, because definitely, because mentors already have gone through that path. So they tell you the ways how you can make your life easy and how you make your goals easy and achievable. Okay, good. So now, last but not least, I would like to share one book. It's called Die Empty. I will highly recommend this book. Whenever you have time, just read few pages about it. This basically book tells us, it basically guides us for reclaiming your passion, finding your voice, and unleashing your brilliance. We all have God-gifted talents that we need to reassure that we can do it. If I can do it, definitely you all can do it. So Die Empty talks about the importance of following your dreams, your passions, your aspirations, and living a meaningful and purposeful life, and using your native gifts that creators have given you to leave a legacy behind, create a legacy and inspire others to tap into their own potential as well. Because I trust all of you, all of you can achieve your goals. It's just a matter of time. It's just a matter of effort in the right direction. And I'm very positive you will get it one day. So never give up, stay positive, and keep working hard. And I will end with one quote I learned from Rumi: from Lord we receive, to humanity we give. So whatever we have, try to share with others. Even if you can help one person, you fulfill your goal. So even start now. Don't wait that we have to have a real white coat and you will start doing it. No, regardless of the white coat, we all are here to help each other. All right, I'll stop here. Thank you, everyone. Thank you, Robin, again, Minahil, Amna. I really appreciate this Saturday morning. And I will wish all of you, and of course, you will be all the future doctors, future aspirations for all of us. And I wish you all best of luck. Thank you.
Thank you so much, Dr. Chima. I really appreciate your inspiring advice. I know that is also something I did very similar, because Krebs cycle, I always forget Krebs cycle. So I'd always have it on my wall to try to remember that for the MCAT and also in medical school. So the link to the TeleShadowing quiz is now live. You'll need a 70% or higher to pass and receive certification for attending today's quiz. It'll be a 2-hour specialty shadowing certificate. And so next month is going to be gastroenterology month, the month of April. So I'm super excited for that. I'm excited to learn with all of you as well. And thank you so much for attending today's session. Looking forward to seeing you next week.